Hello, good morning. Thank you for the invitation for being here today. I'm gonna overlap a little bit with Dr. Omar, um, but I will try to not to bother you too much. Um, this is the agenda for my talk. In the first part, I will talk about atrial fibrillation, new indications for AF ablation in heart failure patients. Some of the novelties from the new guidelines, the 2023 American guidelines that were published 1 week ago, and new tools in AF ablation, which is the the new player in the game, which is pulse field ablation. And in the second part, I will talk about left appendage closure, new indications from the American guidelines, and new devices and technologies to support the implant. This is the Castle heart transplant study. It was published this year. It was a single center randomized controlled trial done in Germany. The patients were patients with symptomatic AFib and an end-stage heart failure referred for heart transplant. And they compared AF ablation versus guideline-guided medical therapy. The endpoint was death from any cause, implantation of LV assistant device, or an urgent heart transplant. And they stopped the trial earlier than expected because of the huge differences between AF ablation and treatment and medical treatment, either in the primary endpoint, the composite, or individually the death from any cause or implantation of left ventricular assist device. Earlier than the heart transplant trial, there was a sub-study of the Cabana trial was published in 2021. These patients were doing better than the heart transplant study. The majority of them were in NIA class 2, and the majority of them were having preserved ejection fraction. The endpoint was death, cardiac arrest, disabling stroke, serious bleeding, and again, they compared drugs, antiarrhythmic drugs versus ablation. And the ablation arm had a 36% relative reduction in the primary composite endpoint and a 43% relative reduction in all-cause mortality. And the last trial I want to show you is the Castle AF. This was published earlier in 2018. And these patients were having low ejection fraction with an ICD. And most of them were in NIA class 2 and 3. The endpoint was death or hospitalization for heart failure, and they compared drugs versus catheter ablation. There was the result was a significant reduction in mortality and a heart failure hospitalization in the AF ablation group compared to drugs. However, we have to be careful with this group of patients, because in the subgroup analysis, there were some patients that did not respond to the ablation therapy. These patients are the older patients, patients with 65-year-old or above, NIA class 3, and ejection fraction less than 25%. So those patients that have a more advanced heart failure are not so well responders to the ablation. And these studies lead to the new indications in the American guidelines. We have a class 1 level of evidence A indication in patients with AF and heart failure with reduced ejection fraction who are on optimal medical therapy. Ablation is beneficial to improve symptoms, quality of life, ventricular function, and cardiovascular outcomes. And we have a class 2A indication in patients with symptomatic AF and heart failure with preserved ejection fraction to improve symptoms and improve quality of life. Always, the authors specify that it's better to select your population because there is a subgroup of patients that are less likely to benefit from catheter ablation, and these patients are those with advanced heart failure, significant ventricular scar on magnetic resonance, severe atrial myopathy, dilation or fibrosis, long-standing persistent AF, prior failed ablations, and advanced age or multiple comorbidities. Some highlights from the guidelines I wanted to point out. The definition of AFib based on the cutoff of 30 seconds is gone, not anymore in the guidelines. Didn't make sense anymore because now we have wearables, we have many ways, loop recorders, long-term loop recorders to for screening of AF. And we detect very, very short episodes of AF, less than 30 seconds. So this cutoff is gone. For patients that you are doubting what to do, to anticoagulate or not to anticoagulate, those on the gray zone, which are men with CHA2DS1 and women with CHA2DS2, you can support your decision based on these additional risk factors, which are high burden of AF, long duration of episodes, persistent or permanent AF, the burden of AF counts, obesity, hypertrophic cardiomyopathy, poorly controlled hypertension, low GFR, proteinuria, or enlarged LA volume. And we have a new recommendation, I think a very important one. For the first one, apixaban and rivaroxaban are recommended for the patients with very low clearance of creatinine, less than 15, or on dialysis. The authors of the guidelines admit that it's not a decision based on the pivotal trials. It's not based on randomized control trials. It's based on observational mostly. But here it is, and at least, we won't feel so guilty or off-label when we put apixaban in a dialysis patient. And the last one is the new recommendations, the new indications for AF catheter ablation. In selected patients, young and with few comorbidities, as first-line therapy, you can do AF ablation to reduce the progression of AF. Before, it was in the European guidelines, it was 2A indication. Now in the American guidelines, it's class 1 level of evidence A. And another important indication, we have for the first time an indication for AF ablation based on the burden of AF and not on the symptoms. This is a 2B indication in selected patients with asymptomatic or minimally symptomatic AF. Catheter ablation may be useful for reducing progression of AF and its associated complications, specifying that this is for young patients with few comorbidities and a moderate to high burden of AF or persistent AF. And yeah, I want to talk about a little bit about PFA. Why not to say it? We're gonna be the first one in Rashid Hospital, the first one in UAE to apply this therapy. We'll have it very soon. And not only we expect to be the first ones, but also the ones with the largest numbers. This is a non-thermal energy, as Dr. Omar said. We don't use cold like cryoablation. We don't use heat like radiofrequency. This is based on pulses, very short pulses of high electrical current that unstabilize the membrane of the cells. The good thing about this technology is that these pulses of electricity are selective for the myocytes, so you don't damage other tissues like the esophagus, phrenic nerve, other structures surrounding the heart. Some cases of coronary spasm have been described, but when the catheter is used off-label, and outside the pulmonary veins. And another good thing of this technology is that it's very, very fast. You apply, the applications are 2.5 seconds, 8 applications per each vein, and in less than half an hour, your PV isolation is done. This slide was shown already. This is to show you in the cell that the pores are created with this technology. This was the first study that we had of pulse field ablation, showing the efficacy of the technology, 84% of freedom of AF at 1 year. And this is another study comparing thermal therapies with PFA. And as you can see, there were no differences in the efficacy at 1 year. So the efficacy is more or less the same. Now we have studies at 1 year, but the most important thing is that it's a very safe technology. The rate of complications is very, very low. The highest complications are in the femoral puncture, and this can be even reduced if you use echo-guided puncture. And these are images of the MRI after PFA, showing that only the wall of the left atrium is affected. You can see the fibrosis, and the esophagus is not altered. So the summary for the first part of the presentation is that we have new class 1A indication for AF ablation as first-line therapy in young patients with few comorbidities. There's a new class 1A indication for AF ablation in heart failure with reduced ejection fraction in patients on optimal medical therapy, and a class 2A indication in heart failure with preserved ejection fraction. And pulse field ablation is the new technology that is truly a revolution for PVI, as it is safe, effective, reproducible, fast, and non-operator dependent. Moving into left appendage closure, these are the two devices that are most frequently used. You probably know them. The Watchman with the new version, the Watchman Flex, and the Amulet, and these are the 3 randomized control trials that we have. The Protect AF, published in 2006, was the first one, showed non-inferiority of the device compared with warfarin, but it was a bit of a disaster in terms of complications, 8.7% procedure-related complications, as we were at the beginning of the learning curve. The Prevail is the second one, comparing Watchman versus warfarin. It didn't reach non-inferiority, but it showed better rate, reduced rate of complications compared to the Protect AF. And the last one is the Prey 17, comparing Watchman and Amulet to Apixaban. It showed non-inferiority and a very reduced rate of complications, 1.3% of complications. The new guidelines, American guidelines for the management of atrial fibrillation, elevate the indication for left appendage closure from 2B to 2A in patients with contraindication for long-term oral anticoagulation. And they state a new indication for left appendage closure with class 2B indication in patients with high risk of major bleeding on oral anticoagulants. These are the old guidelines, 2B indication, as you can see. This is to show you that there are other devices in the market, apart from the Amulet and the Watchman. But the evidence, of course, is much shorter, more limited than the Watchman and the Amulet. And I wanted to show you this this video of the lariat ligation system is an epicardial ligation system. The advantage of this system is that you don't leave any device inside the heart of the patient. Of course, I think it's a complicated procedure because you have to do transeptal puncture, you have to do epicardial puncture, which is not easy, but looks amazing. Of course, we don't have much evidence. The evidence in the literature I found is very, very limited. But yeah, looks very good. So here you end your ligation, you remove the catheter, the transeptal catheter, the transeptal puncture, and then you adjust your ligation. Looks very nice, I don't know, in practice. These are other trials that are coming, are actually ongoing. 3 trials on eligible patients for anticoagulation, patients with no contraindication for anticoagulation, but at high risk of bleeding, and 3 clinical trials coming up for patients with contraindication of oral anticoagulation. And the last slide I wanted to show you, this is a very nice study, randomized control. And they used artificial intelligence together with a CT scan to do a simulation, a computer simulation of the procedure. They divided the patients in classical approach. You do the CT scan, you do your measurements, and that's it. And the second approach, which is the last one. And the second approach, which is with this simulation, CT-based simulation approach. And all the numbers are significant. Less leakages, less thrombus of the device, less devices used, and less repositioning. So I think this artificial intelligence applied to the procedure of left appendage closure, to know the anatomy and how you're going to do the procedure, to choose the device and the position, everything looks very promising. The conclusions for the second part is that the level of evidence for left appendage closure devices is still limited. Nevertheless, the last 2023 guidelines on management of AF have elevated the indication for left appendage closure to class 2A in patients with contraindication for anticoagulation, and open the indication to patients with high risk of bleeding or intolerance to anticoagulation with a class 2B indication. The improvements in the devices and the increased experience of the operators have decreased significantly the rate of complications, and the complication rate can be reduced even more in the future with the use of artificial intelligence to tailor the procedure to each patient and anatomy. Thank you so much.